Hi everyone, good morning. My name is Humaid, I'm the emergency R1. Today, me and Ahmed, the emergency R4, will talk about the THALES trial. So the THALES trial is a trial that investigates Ticagrelor plus aspirin versus aspirin alone in acute ischemic stroke or TIA, which this is study conducted from January 2018 till October 2019, and it was published in July 16, 2020. So this is our objectives for today. So the around 5 to 10% for the patient who had acute ischemic stroke or TIA, they will have subsequent ischemic stroke. And the aspirin is known to use to prevent this subsequent ischemic stroke. So there is another study shows that when use double antiplatelets versus mono antiplatelets therapy, it was superior. And that was chance trial was conducted in 2013. They compared the aspirin and clopidogrel versus aspirin alone. And both groups, the treatment duration, it was 90 days. So for the intervention group, there were aspirin plus clopidogrel for 21 days, then continue with the clopidogrel alone for the rest of the 90 days versus the aspirin for the whole 90 days. So the study comes with that the aspirin plus clopidogrel is superior. But this study, it was just in the Chinese population, so that it's opened a door for another study called Point Trial. It was conducted in 2018. It was a multinational trial. They also compare aspirin plus clopidogrel versus aspirin alone for the 90 days for the both group, and it comes also that's dual antiplatelets. It's superior to the aspirin alone. So there is also another another antiplatelets. So it's open door for another, like to investigate another antiplatelets medications called Ticagrelor. And that's what happened in the Socrates trial 2016, which compared Ticagrelor alone for 90 days versus aspirin alone. But this is the trial shows that there is no difference between both of them. In subgroup who received Ticagrelor before the randomization, they were taking aspirin. And this subgroup, they noticed that the subsequent ischemia, it was lower. So that's open like the door for investigator to ask if adding the Ticagrelor to the aspirin for 30 days, it reducing the risk of subsequent stroke or death among the patient with acute non-cardiomyopathic stroke. So how they enrolled the population on this study. So the included criteria, it was the patient above 40 years old who had mild to moderate ischemic stroke that scores 5 or less in NIHSS score, or their high risk of TIA, an ABCD score that scores 6 or higher, or symptomatic intracranial or extracranial arterial stenosis that could count for the TIA, or the patient not undergoing thrombolysis or thrombectomy. What is the exclusion criteria? The exclusion criteria is that the patient will have intravenous or intra-arterial thrombolysis or mechanistic thrombectomy within 24 hours, or a patient who shows intracranial bleeding or another condition than the cerebral ischemia on CT or MRI, or using like anticoagulation or specific antiplatelets that plans to have hypersensitivity to Ticagrelor or aspirin, history of atrial fibrillation, ventricular aneurysm, cardioembolic causes that was suspecting for the stroke or the TIA, or plan for a carotid endarterectomy required to discontinue the trial or known for bleeding vessels, coagulation disorder, history of intracerebral hemorrhage, or GI bleed within past 6 months, or major surgery with the past 30 days. So what is the design of the study? It was multi-center, randomized, double-blinded, placebo-controlled, parallel group trial conducted in 414 sites in 28 countries. So, and then randomization occurred within 24 hours after the onset of symptoms or evidence of a stroke in a waking patient from sleep within 24 hours from the last time they will know. Both the groups, they had less dosing of loading dose of aspirin was recommended if the patient had already received aspirin after the symptoms onset, but before the randomization. And both the group were treated according to the standard of care. And it was used the method of intention to treat analysis. Okay, so what is the intervention arm? The intervention arm, it was Ticagrelor, loading dose 180 milligrams, plus aspirin loading dose 300 milligrams to 325 milligrams. Then maintenance dose for Ticagrelor 90 milligrams BID for 30 days, and the aspirin 700 to 100 milligram were recommended daily. Versus the comparison arm, it was placebo, again 180 milligram plus aspirin loading dose 300 to 325. And subsequent maintenance dose, it was aspirin recommended from 75 milligram to 100 milligram. So what is the outcomes that the investigators he needs to see in this study? The primary outcomes, the stroke and death at the 30 days. The secondary, it was subsequent ischemic stroke or disability measures as 1 or above score on the modified Rankin scale. Yes, and the safety of the study, it was any severe bleeding, consider fetal bleeding or any other like compromise of the stability of hemodynamically of the patient, or any transformation from asymptomatic from ischemic stroke to asymptomatic hemorrhagic infarction. So now I'll move to the microphone to Ahmed to speak about the evidence-based topic.
Thank you, Ahmed. Do you hear me, guys?
Yes.
Okay. So thank you, Ahmed. Our EBM topic for today will be about intention to treat analysis. We will touch briefly on the concept. Then we will talk about the advantages and disadvantages of using intention to treat analysis. And we will end by talking about the application of intention to treat analysis in our study. So to talk about the concept, we know that RCT is the ideal design for investigating the efficacy and the safety of any new intervention that we want to do in medicine. And basically, we will have two groups in the RCT, the control and the intervention arm. And in the ideal world, we would like to have a really compliant participants in both groups. But unfortunately, in the ideal world, we will have some participants who will deviate from the protocol, either because they were not compliant or sometimes because we will have a missing data at the end. And sometimes some of the participants will decide to withdraw from the study. Sometimes because the treatment is working and they decided to stop, and sometimes because of the side effect, they will decide to stop. So the researcher will have a question, what to do with those participants who are not compliant and deviated from the protocol. And to explain this, I will give you an example of an RCT, the true outcome of that RCT, that there is no difference with 75% in both group, the control and the intervention arm. You will have 3 participants with good outcome and 1 participant with bad outcome in both group. And let's say that one of the bad outcome participants who had like a participant who had a bad outcome in the intervention group decided to deviate from the protocol. What to do with that participants? We have three options. Number one, either to exclude that participants from the intervention group, and the analysis that we will do in that case, we call it per protocol analysis. Or number two, that because this participant is not taking the intervention that we want to, we will add him to the control group. And this analysis, we will call it as treated analysis. The third option is to leave that participants in the same group. This is called intention to treat analysis. So what will happen to the results in that case? In case number one, which is the per protocol, the control group will stay 75%, but the intervention group, we will have 3 out of 3 participants with good outcome. So the outcome will become 100%. In the second option, which is as treated analysis, in the control group, we will have now 3 out of 5 participants with good outcome, which is 60% now. And in the intervention group, it will be 100%. But if we decided to do intention to treat analysis, the result will be the same. In the control group will be 75%, and also in the intervention group. To make it more clear, let's say that one of the participants with good outcome decided to deviate from the protocol. What to do with that participant? Again, we have 3 options. Option number 1, which is per protocol. In that case, the control group will stay 75%, but the intervention group now will have 2 out of 3 participants with good outcome, which is 67%. And if we decided to do as treated analysis, the control group now will have 4 out of 5 participants with good outcome, which is 80%. And the intervention group will be 67%. And if we decided to do intention to treat analysis, both groups will stay 75%. Now, in this example, it's very simple with only 4 participants. Of course, in a real study, it will be a larger group with more crossover between the 2 groups. So to summarize it, intention to treat analysis is basically analyzing all randomized patients in their same group, regardless if they were adhered to the treatment or if they would withdraw or they deviated from the protocol. Any patient that will be randomized to one group will be analyzed in the same group. Now let's talk about the advantages of using intention to treat analysis. I will give you 5 advantages of intention to treat analysis. Number 1, as we said, in the real world, most of the participants will not follow the protocol that you have. So this is an option to use. Number 2, using intention to treat analysis will minimize your selection bias and your estimated treatment efficacy. Number 3, it will preserve the sample size and power, which will in return will minimize type 1 error in your study. Number 4, it will also preserve the baseline characteristic between each group if you will decide to keep each participant in the same group. And number 5, if you want to improve your RCT report, it's best to use intention to treat analysis as per the consort statement. Now, on the other hand, I will give you 4 disadvantages of using intention to treat analysis. Number 1, if you have a higher rate of missing data, protocol deviation, that can bias your results towards the null effect. Number 2, if you will have also a higher rate of non-compliance patients that or participants that you will decide to keep in the same group, that might dilute your effect, especially if those patients are not taking the intervention that you want. Number 3, if you will have a higher rate of protocol deviation, also you will have a higher rate of a crossover between the two groups, which will make it difficult to analyze, especially if you have a large sample size. And finally, using intention to treat analysis can increase your type 2 error and give you a lot of false negative results. Talking about the application of intention to treat analysis, FDA guidelines recommend using intention to treat analysis in their studies, and also the CPMP guideline recommend using intention to treat analysis. Actually, they're saying intention to treat analysis and per protocol analysis, if they use together and they reached the same conclusion, your confidence will increase in your results. And if it is a superiority trial, they're recommending using intention to treat analysis as a primary method. And in non-inferiority trial, they're recommending using both intention to treat and per protocol analysis, because both of them will have equal importance. In our study, we can see that there was 11,073 participants, 57 of them who did not meet the criteria were excluded. They ended up with 11,016 patients who were randomized into two groups. In the intervention arm, there was 5,523 participants, and in the control group, there was 5,493. In both the groups, we can notice that there was some protocol deviation and participants who discontinued the treatment due to severe side effects, or they withdrew because it was a patient decision, or there was another reasons. But what we can see that the final analysis number was the same as the randomized patient. So you can see that in the control group, it was the same number, 5,493. That they analyzed at the end, and also in the control group, which was the same number. So to summarize it, intention to treat analysis is basically once randomized, always analyzed. And now we will go back to Humaid to talk about the results.
Thank you, Ahmed. So in the result, we need first to talk about the characteristic of the patients, the baseline characteristics. In the both group, 20% had previous stroke or TIA, and 13% of this patient were taking aspirin. But in both group, they share the similar, also the similar age, gender, race, and even the same past medical history. So the results of this study comes that in the intervention group, it was lower of incidence of a stroke and death at 30 days, and also lower in subsequent ischemic stroke. But there was no difference in the disability on modified Rankin scales. And in the intervention group, that shows there is a higher risk of severe hemorrhage and cerebral hemorrhage. So what was the author conclusion? Among the patient with mild to moderate ischemic stroke who scores 5 or less in IHS score or TIA, who were not undergoing intravenous or endovascular thrombolysis, the risk of composite stroke or death within 30 days was lower with the Ticagrelor and aspirin group. But the incidence of the disability, didn't differ between them significantly. And the risk of severe bleeding was more frequent in the Ticagrelor group. So what is the strength and the limitation of the study? The strength, it is in a large multi-center randomized double-blinded placebo-controlled parallel group trial. The efficacy and safety analysis was based on the intention to treat in both the group. The both group has a similar baseline characteristic in the blood pressure, and I mean in the past medical history, even in the stroke and TIA. And in the both group, the follow-up was complete, except 15 patients. In the limitation, the large exclusion criteria that limits the population this result would apply to. And around 60% of the patients had 3 or less in the NHIS score. And 7 to 14% of the patients discontinue the trial because of adverse effect that needs to terminate the trial for them. So what we concluded from this trial, the trial shares that similar results for the past barriers evidence that the dual antiplatelets is superior to the monotherapy antiplatelets. But in the THALES trial and BOINT trial, the risk of severe hemorrhagic bleeding, it was higher in the intervention groups. But in the CHANCE trial, it shows no moderate or severe bleeding. Also, that's the use of, we can use as use of Ticagrelor plus aspirin as alternative of clopidogrel and aspirin on the dual antiplatelets. So this was our talk for today, and thank you. Any questions?